Hello, everybody. My name is Mirvat Alasnag. I'm an interventional cardiologist at King Fahd Armed Forces Hospital. And with me today is Dr. Shamir Mehta. He's the Douglas Holder Endowed Chair in Interventional Cardiology and the Director of Interventional Cardiology at McMaster in Canada. He presented the complete quality of life data at the late-breaking clinical trial session at the American College of Cardiology earlier this week. And we're here to provide you, the viewers of PCR Online, a summary of this trial. So as you know, the complete trial was published in 2019, and it reported a significant reduction in major adverse cardiovascular events, namely myocardial infarction and cardiovascular death, with complete revascularization following an ST elevation MI. Currently, it is a Class 1 recommendation to perform complete revascularization in patients post-STEMI. However, patient-centered outcomes are also important to capture, and this is where the sub-analysis led by Dr. Mehta and his group is valuable to guide us in our discussions with individual patients and hopefully help us with the truly an informed consent process. So I'll start by asking you, could you briefly describe the methods used for this study and the most important results?
Yeah, thank you for inviting me. This analysis focused on, as you said, patient-reported outcomes. So we've reported the data on, physician reported outcomes, so major cardiovascular events. Here, we wanted to take the opposite point of view and find out what a patient's experience was who had complete revascularization versus a culprit-only strategy. And so what we used was the Seattle Angina Questionnaire, which is a validated questionnaire in mainly a stable ischemic population of patients. But we used it here in the complete trial to evaluate angina-related quality of life. And so the questionnaire was administered to all patients at randomization and then 6 months, and then at the final follow-up at 3 years.
So, you had a 3-point follow-up for these patients. Do you think this 3-point follow-up is sufficient in real life and for a practicing cardiologist?
Yeah, I mean, it's not really follow-up. It's the time at which we are assessing their quality of life. And so, there are obviously cuts in time where we're assessing quality of life. So, how did you feel at 6 months? How did you feel at 3 years? And so those are the time points that we have. Now, you could do more often. How did you feel at 3 months? How did you do at 6 months? How did you feel at 9 months? How did you feel at 12 months? I mean, there's really no end to how many times you can ask a patient how they feel. But I think this is practical to get a feel, an idea of how patients are doing from, in terms of quality of life, particularly how they're doing years later. So the long-term follow-up, which is one of the big advantages of the complete trial, in contrast to many of the other trials where we focused on long-term outcomes. So we have patients followed up to about 5 years.
Absolutely. And we all recognize that coronary artery disease is a progressive disease. So even though they don't have symptoms now, they may progress and have symptoms later down the line from different vessels and so on. So just examining the data a little bit more, there was a 13% crossover from the culprit-only arm to multivessel. So could that account for the narrow difference in the angina status at the end of the study?
Yeah, so just to clarify, the crossover in the trial was very low, right? It was only it was under 3% or 2% that we reported in the New England Journal paper. So those are crossovers where the patient would receive, for example, if they were in the culprit lesion-only group, they would receive complete revascularization when they should have been in the culprit lesion-only group. But the protocol said that if a patient fails the culprit lesion-only group, so if they have an outcome, if they have an MI or they have a hospitalization for unstable angina, then yes, of course, you can do a non-culprit lesion PCI. So first, they would have already met a primary endpoint in the trial, and it would be reported. And so after that time point, then we could have a crossover. But the way it potentially could affect quality of life is a patient may have had debilitating or intractable angina at some point in the trial, admitted to hospital with a diagnosis, whether that be MI or non-STEMI, and had or unstable angina or ischemia-driven revascularization, had a non-culprit lesion PCI, and then they felt fantastic. And so when the questionnaire is administered at 3 years, they may have checked off, oh, I feel very good, even though they were randomized to the culprit lesion only group. So yes, in that respect, it may have narrowed the overall differences. So in order for us to look at that, we looked at total angina burden. So any type of anginal event through the course of the trial from randomization to follow-up. And there was really a substantial benefit of complete revascularization when you look at it from that perspective, about a 9 to 10% absolute reduction, which is very, very large. But if you just look at follow-up, if you just focus on follow-up and the absolute difference in the groups, it's still about 3%. You're looking at antiplatelet therapy trials, for example, versus placebo, you're talking about absolute differences of 2%. So even 3%, when you look at everything, is still not a trivial difference.
The majority of those had an event, is that correct? So the majority of those, it wasn't just angina, but it was also, they had some kind of an event, an ACS of some sort, non-STEMI.
Yeah, about 13% of patients who, so of the patients who had a non-culprit lesion PCI, yes, most of those patients had an event prior to their non-culprit lesion PCI.
And so, and more than 80% stenosis was identified as the cutoff, beyond which angina relief was achieved in the complete revascularization arm. And this was based on primarily QCA, I understand.
No, well, it was based on both. So we used 80%. So it wasn't really a cutoff, it was a pre-specified subgroup analysis in the trial. So we had 4 major pre-specified subgroup analyses in the main complete trial, of which that was one of them. And the others being the timing of the non-culprit lesion revascularization, one being the syntax score, the median syntax score. There are papers forthcoming on all of these issues. And angiographic stenosis obviously was an important one, we thought. And so we specified 80% visual because that's what people use in the cath lab. We don't have an angiographic core lab in real time. So we wanted to go with the clinically relevant one, which was the 80% visual. But there were a number of patients who didn't have an 80% visual. And of course, we have angiographic QCA data in all of the all of the 4,000 patients in the trial. So we used the QCA where we had a missing visual. But the results were very striking, and it showed that that's where really we saw the angina benefit of non-culprit lesion PCI was in the patients with a tighter non-culprit lesion. And those that had lesions that were less significant, we didn't really see a benefit in terms of angina relief in that population. I should say that the second co-primary outcome of the trial, CV death, MI, and urgent revascularization was also significantly reduced, though, even in patients with lesions of less than 80%. But in terms of purely angina relief, as reported by the patient, again, not by the physician, by the patient, the benefit was in the tighter lesions.
And I know there was an OCT sub-study. It was a smaller group of patients. But do you think at all OCT parameters would have been discriminatory if they were used?
It's hard to know. I see the real value of OCT in this setting. I see two major reasons to do it. One is to help guide stent placement. I think that's one that we're getting better at, and that the data is improving on. And I think the Illumium 4 trial will help even move that to a different level if it's a positive trial. But the second more intriguing part of OCT, I think, in this setting is to characterize the plaque morphology and see if we can target those lesions that are prone to future plaque rupture. Plaque rupture and angina may have some common characteristics, but they may be completely dissociated from each other. So, for example, you could have a 50% stenosis, which with a very thin fibrous plaque, very large lipid core, that may not cause any angina at all. And that is the plaque that ruptures and causes a fatal event or a big MI. Now, the place where they both intersect is that the vulnerable plaques, the ones that I just described, are most commonly seen in the tighter lesions. That's the thing. So tighter lesions are much more likely to represent or to have these vulnerable plaques. And we showed exactly that in the OCT sub-study led by my colleague, Dr. Pinella.
So another point that we probably should be discussing is that approximately 50% of those enrolled had no angina. So how do we explain an overall reduction in the total angina burden that you mentioned earlier in the complete revascularization arm?
Yeah, it was striking that 50%. I think, nobody's ever done Seattle angina questionnaire in STEMI for multivessel disease. It's the first time it was ever done, and it's fascinating that only about half of the patients reported having any symptoms before their culprit lesion ruptured. And it's pretty scary when you think about it in some ways. But yeah, that probably narrowed the difference in terms of pure angina at the end of the trial. So it's still remarkable that we saw a 3% difference. But in the tighter lesions, the ones that did have angina and the ones that did have a tighter lesion, the absolute difference there was 5%. So really quite, I think that's I would call that a clinically relevant difference.
And do you think if more diabetic patients were included, the results would have been different? I practice in a part of the world where diabetes, impaired glucose tolerance, et cetera, is very prevalent. The complete trial enrolled 19% diabetic patients only. So just wondering.
Yeah. So remember now that you have to be a little careful with diabetes, because in the various types of CAD that we look at. So, if you go to, for example, stable angina, so there we're looking at the oldest population of patients. And there they often have established type 2 diabetes, for example. So we take an ischemia trial type population, for example. And then we move down to the non-STEMI population. Non-STEMI population is an older population. They have more comorbidities. They have relatively higher rates of type 2 diabetes. And then we have the STEMI population. And STEMI is unique in that it is often the first manifestation of coronary disease for many of these patients. STEMI is usually a younger patient population, much younger patient population than stable ischemic heart disease. So the median age here in our trial was about 60, 61 years. Substantial number of patients that present in their 50s and in their late 40s. So they've never seen a doctor. These patients have never seen a doctor before. Many of them have occult diabetes. So this is the number that we're reporting here is known diabetes when they come into the hospital. Many are subsequently diagnosed either during that admission or within months after follow-up, because now they're in touch with the healthcare system. They subsequently get diagnosed with diabetes. So it's generally a younger population. And that's manifest also by other things. So not only clinical comorbidities, but also angiographic severity of disease. So when you look, for example, at stable ischemic heart disease population, we're talking syntax scores that average maybe about 20 or so, even higher than that. When you're looking at a STEMI multivessel disease population, your syntax scores are much lower than that. They're probably in the range of about 8 to 10. So they're much lower. And it all has to do, I think, with age and the timing of when they develop their plaque rupture.
Absolutely. Well, thank you. That was, very interesting. But I think the most interesting part of it is as we mentioned at the start of this interview, that it's focused on our patients and what they report back to us and what their expectations for us to do. And I think some of the data that was presented here at ACC this year is interesting, including using PCSK9 inhibitors and so on in these kind of patients. Just maybe perhaps evaluating that role.
We're looking at that too. That question is an interesting one. I think is starting PCSK9 inhibitor early in this population. It's a terrific question, and people have looked at it. The Pac-Man study at this meeting looked at that question. Routine administration of PCSK9 inhibitor, I think, is an interesting question, particularly when you look worldwide. There is non-compliance with statin therapy that approaches 30%. Like 1 in 3 are not on statins. So I think it's a great question.
Absolutely. And again, thank you so much for being with us today and dissecting this trial with us. We will be looking forward to the sub-analyses that you mentioned with respect to syntax score and so on. And thank you to our viewers. This is going to be available to you at PCR Online along with the slide set. Thank you.
Great. Thank you.